बहुत आ रहा है पीछे से।
जी
शोर बहुत आ रहा है पीछे से।
शोर पीछे है बहुत, मैं क्या करूँ?
चलें
मैं
आप
डिजिटल
कंटिन्यू।
लाइब्रेरी में हूँ तो यहाँ पीछे शोर है, तो मैं क्या करूँ?
ठीक है सर।
अभी आ रही है वन से?
नहीं अब नहीं आ रहा।
नहीं, शोर आ रहा है, नहीं आ रहा?
नहीं सर अब नहीं आ रहा है शोर।
एक मिनट, एक सेकंड के लिए रुको। हाँ, हेलो।
जी सर।
अब ठीक है?
जी सर ठीक है।
Okay, okay. So today I'll discuss with you testicular disorders. Before I start my presentation, I would like to share my anatomy of the testis, and then we will start the proper topic. So this is the TS section of the testis, and it is present in pair order, and on both sides it has got two poles. One is the upper pole, the other is the lower pole, and the upper pole continues with the epididymis, attached with the epididymis. And epididymis has got three parts: head of the epididymis, tail, body, and then tail, and that it continues as pectus deferens or vas deferens. Inside the testis, there are seminiferous tubules, and in which spermatogonia sperms are formed, and they get collected, and then collected over here in the head, epididymis, and then they're released accordingly. Then these are the layers of the testis. From outside inwards, initially it's the skin, and after that, testis is invested in cremastic muscle. The cremastic muscle has got three layers. One is the outer fascia, which is called external spermatic fascia. Then cremastic muscle is there. Then internal spermatic fascia is there. So there are three layers of the cremastic muscle, like muscle and fascia. And after that, the two layers of the two coverings of the testis come. These are tunica vaginalis, tunica albuginea, and tunica musculosa. This tunica vaginalis has got two layers. One is the parietal layer, and the other one is the visceral layer, which is directly connected to the testis. And there's a potential space in between these two layers, like parietal and visceral layer, and in which sometimes fluid gets collected, and that we call, you must be knowing the hydrocele. Actually, the hydrocele is the fluid collection over here, like in between these two layers, this parietal layer and visceral layer. And after that comes the tunica albuginea, and then tunica vesiculosa. These are the three layers of the testis. After the vessels are come. And then these are the figures which are showing blood supply of the testis. So the testis is supplied on both sides with the testicular artery mainly, which is coming directly from abdominal aorta. And the other two arteries also supplies these testis. One is the cremastic artery, which is coming from inferior epigastric branch of the external iliac artery. And the other one is the artery called ductus deferens, which is coming from this internal iliac artery, which is giving a branch of the vesical artery. For vesical artery, this artery comes. So three vessels are supplying the testis. One is the testicular artery, which is directly coming from the abdominal aorta, and the other one is coming cremastic artery, which is coming from inferior epigastric artery, which is the branch of the external iliac artery. And the third one is the branch of the vesical artery, which is coming from internal iliac artery. And as far as the veins are concerned, and the testicular veins, they form a plexus, which is called tympaniform plexus in the testis, and they get together and they form testicular veins. So initially in the inguinal canal there are 4 testicular veins, and they become 2 when they reach to the deep inguinal ring, and after that they become single bands on both sides, right and left. Okay, so the tympaniform plexus and then testicular veins, and then one vein is formed. So on the right side, this testicular vein is ending in the or draining in the inferior renal cavity, and on the left side it drains in the renal vein, left renal vein, and then renal vein drains into inferior renal cavity. Okay, it's clear now. Let's move to the other. Now I'm going to discuss with you some testicular disorders, starting from the varicocele, then I'll discuss testicular torsion, and then epidermolysis. So the first of all, I'll discuss varicocele. Varicocele is dilated, defined as a varicose dilatation of the veins draining the testes. These are testicular veins, or the tympaniform plexus. So it's a dilatation of the veins which are draining the testes. It's more common on the left side and then on the right side. You can see on the right side the vein is directly draining in the inferior vena cava. The left side is draining into the left renal vein. So you can see this dilatation of the vessels over here, and this we call, these dilatations we call varicocele. On the right side there is no varicocele, no dilatation. What's the etiology behind? Like usually in these gonadal veins, there are valves which are draining the blood from the testis to the on the right side to the inferior vena cava, and on the left side to the renal vein. But if these valves becomes dysfunctioned, then what happens? Usually it works one-way valve, draining blood from testicular veins to the upper side, like inferior vena cava and renal vein. But when these valves become dysfunction, then what happens that the blood comes back to the testicular vein, and there's a pooling of the blood is there in the tympaniform plexus, and they causes dilated veins, which we call varicocele. When the valves don't function properly, so there's a backflow of the blood, pooling of the blood, and which causes dilated veins, and which feels like the varicocele. What's the etiology? In 15 to 20% of the pregnant males, this disease is present, and usually it is on the left side. And there are different reasons why it is more common on the left side than right. And presence during late childhood or adolescence, and usually the cause is what? Incompetence of the valves in the proximal testicular vein. So there's a backflow of the blood from upside down, and there will be dilatation of the plexus testicular veins, and mostly they are idiopathic. So when there's no other cause, and the varicocele is, then we'll call this varicocele as a primary varicocele. And if there is some obstruction in the left testicular vein, like because of the renal tumor or nephrectomy is being done before, then this varicocele will be called secondary varicocele. So what is the difference between primary and secondary varicocele? In primary varicocele, there is no cause, and it's idiopathic. And if there is some obstruction of the left testicular vein because of the usually because of the renal tumor or previously nephrectomy has been done, then this will cause obstruction of the renal vein, and then there will be pooling of the blood in the testicular veins, and then the testicular veins, sometimes complexes, will become dilated, and they will cause varicocele. And clinically, how can we differentiate between the primary varicocele and secondary varicocele? Because of this test, like when it does not decompress in the supine position, what happens when the patient of the varicocele it becomes more prominent on standing position. And when we ask the patient to change the position, become supine, lie down, then these varicocele, these veins becomes emptied, decompressed, and varicocele goes away. This is normal veins. You can tell it the normal veins. So it can get decompressed in supine position. This happens in case of the primary varicocele. But if it doesn't get decompressed in the supine position, then we call it a secondary. It is because of the some obstruction in the vein. So it will not get decompressed, and we'll call it secondary varicocele. So how can you differentiate between a primary varicocele and a secondary varicocele? Clinically, ask the patient to lie down and then try to empty the veins. Primary will get emptied or decompressed, and the secondary varicocele will not get decompressed. This is how you can differentiate clinically between primary and secondary varicocele. Why it is more common on the left side? Because of the high pressure of the blood in the renal vein. Because of that high pressure, the blood becomes cooled in the testicle, which causes varicocele. So these are the dilated veins you can see, and over the skin it will appear like this. If it is a grade 3 varicocele, then it will look like this. Dilated veins. So what are the clinical features? How the patient presents? Usually and mostly this varicocele is asymptomatic, so without any symptom it presents. And if the symptoms are there, if its grade is high, like grade 3, then the symptoms are dragging discomfort. Usually, when the patient is standing, the patient will feel discomfort. And at the end of the day, if the whole day the patient is walking, standing, working, and at the end of the day, the patient will feel this dragging discomfort. And when the patient is examined in a standing position, the affected side will be a little lower than the body. This is the second side. The first symptom is discomfort at the end of the day in standing position, and when you examine the patient in standing position, then the affected side will hang down than normal, and on palpation there will be feeling of bag of worms. When you palpate the affected side, then there will be feeling of bag of worms. And cough impulse will be positive. How can you appreciate it? Keep your hands over the dilated veins and ask the patient to cough, then you can feel a cough impulse like you feel it in case of the guanyal hernia. Then the underlying testis will be normal to palpation initially, but if it is a long-standing case, then testis may become smaller than the opposite side and softer. So these are the symptoms and signs of a varicocele. Okay, discomfort, dragging discomfort during on standing position at the end of the day, and the affected side will be a little lower than the normal, and there will be feeling of bag of worms. If you feel like bag of worms, cough impulse will be positive, and the underlying testis will be normal initially, but if it is a long-standing case, then the testis will be smaller and softer. in a grade 2 varicose. If it's a grade 1, then only on ultrasound can be seen. So it is impalpable on examination, but it can be observed only on ultrasound. This is grade 1. Grade 2, it is palpable but not visible. So on examination, the directly field will be palpable, but it will not be visible, as I showed you in the picture how it can be seen. But if it's grade 3, then it will be seen also. So the grade 1 only visible on ultrasound, and grade 2 it is only palpable, and grade 3 being visible also along with the as it is palpable also and visible also. So these are the grading of varicose. What investigations will you suggest for varicose? First, obviously, ultrasound, which can help out the small, even small varicose can be diagnosed in this center. In grade 1 can be diagnosed with ultrasound. And what other investigation we'd like to do is the sound of the abdomen, especially the left kidney, because there are chances of, if the patient has got tumor, renal tumor, but it can obstruct the renal vein and it can lead to dilatation of the testicular vein, like varicose. So, and ultrasound of the lower abdomen as well. If any other obstruction is there, any other tumor is lying there which is compressing testicular vein, it can lead to varicose formation. So we have to exclude, and we can differentiate primary and secondary visible ultrasound of the lower abdomen. So clinically, you can differentiate between whether the varicose is primary or secondary. And the second confirmatory test is ultrasonography of the lower abdomen, which can again differentiate between the primary and secondary varicose. There's a little relationship between this spermatogenesis and varicose. So most of the patients present along with the varicose infertility also. So it has got some relationship with the decreased formation of the sperms that we call oligospermia. So the infertility may be present in these patients of the varicose, and if the patient is treated, the varicocelectomy is done. Literature supports that some patients may improve their sperm count and infertility. But the other says that there's no difference between after treatment or after varicocelectomy, no difference is made on the count of the sperms. But some literature supports that varicocelectomy helps in improving the semen quality and quantity. So what is the treatment for asymptomatic?
आवाज नहीं आ रही आपकी.
Hello?
सर अपना माइक साइड करें, आवाज सही नहीं आ रही.
जी. Okay, you can hear me now?
जी सर.
Okay, so the treatment is like if the patient is asymptomatic, then there's no need to treat this condition. And if the patient is symptomatic, the first line of treatment is percutaneous embolization of the renal veins. But if this facility is available in this hospital where the patient is lying, then this should be the first line intervention. How it happens? Like femoral vein is accessed, we do the angiography, and through this femoral vein, this renal vein is accessed, and then through it, this embolization material is injected, and this causes embolization of the veins. Other choice, mostly the patients treated with the surgical ligation of the testicular veins. it can be done by two methods, open method and laparoscopy. Laparoscopically it can be done. This is open varicocelectomy and laparoscopic varicocectomy. In open varicocelectomy, there are 2 or 3 surgery routes are there. One is the low ligation, the other one is the high ligation. Low ligation, the common operation which is being done in most of the surgical units are open low ligation procedure, and it's done through the inguinal incision, as incision which is given for hernia. Through the same incision, a little bit smaller one, inguinal canal is opened, and the testicular veins are accessed, separated. Then ductus deferens or vas deferens is separated, and the tube artery is separated, and the veins are dissected and ligated. So this is the low ligation. In high ligation, it is done extraperitoneally, and that is called Palomo's method. And in that, testicular vein is approached extraperitoneally, it is ligated over there. The other method of doing it is laparoscopically. Laparoscopically through the umbilicus, gas is insufflated, and two assisting trocars are applied, and the testicular vein is identified, that vein is dissected, and then this vein is ligated, clipped, or maybe suture ligation can be done. There are 2 ways of doing it. And the non-surgical treatment is embolization, percutaneous embolization. But this is the open method in which these dilated veins are accessed. They are separated from the testicular artery and ductus deferens, and now these veins are ligated. And this is the way how the laparoscopic procedure works. These veins are dissected, and then over here they are clipped or diathermized, or harmonic scalpel can be used to diathermize, to ligate it, or to burn it. So there are 2 ways of doing it. Now we move towards the torsion of the testis. Torsion of the testis means twisting of the testis. So it's a condition in which the testicles are twisted in such a way that the blood supply becomes compromised. So the testicular torsion is twisting of the testicle is done, and blood supply becomes compromised. What is the fate? So if the testicular torsion is done as
सर अपना माइक चेंज कर लें अगर कोई आईटी वाला है उधर.
आवाज बिल्कुल नहीं आ रही
सर, आवाज बिल्कुल डिस्टर्ब हो रही है.
अब आ रही?
जी सर, थोड़ा आप जोर से बोलें. जी सर, सही है. थोड़ा आप ऊंची आवाज में बोलें सर, सही आएगी.
अभी आ रही है?
ठीक है सर.
अच्छा. So the testicular torsion is a condition when the testicle becomes twisted and the blood supply is compromised. What is the fate? So initially, for the initial 6 hours, if the patient presents within 6 hours, is treated, then there are high chances that, like 100% chances of survival of the testes. But if the patient presents late, after 6 hours, 12 hours, 24 hours, then the chances of survival of the testes is minimum. So you can say that it's a surgical emergency. Whenever the patient presents with this testis torsion, then it should be treated on an emergency basis. This is the only way to make the testis survive. Otherwise, the testis will get atrophied. And earlier the surgery, better will be the outcome. So in this way, the testis become taunted or twisted over at the diaphragms. The blood supply also becomes compromised in this way, and the testis becomes taunted. This is another diagrammatic presentation. This is the normal one, and in this condition, the testis becomes taunted, and this is this. You can see the dilated blood supply, and it becomes dilated because of the obstruction, and blood supply is lost initially. The venous supply is lost, and then the arterial supply is lost. And if it stays for more than 6 hours, then there are chances of the death of the testis. But you can see the color change over here as well. What are the causes? High investment of tunica vaginalis. This is the one cause. Inversion of the testis is the other cause. And the diastole is very sweet. And there are chances. And there will be history of some fall in which the abdominal muscles become contracted very strongly. Then what happens? The cremaster muscle also gets contracted, and it causes pull of the testis upstairs. And if there are if this high investment is there, investment of the tunica vaginalis is there, or inversion of the testis is present, then the testis may become twisted. So this is parallel attachment of the cremaster favors rotation of the testis around the vertical axis. So this is the cause why testis twisting occurs. There are two main factors that define damage to the testis. They are the time factor and the degree of rotation. The extent of rotation, extent of the twist. If the twist is 720 degree, means 2 times if the testis becomes twisted, then the rapid ischemia will be there. And if the testis is twisted once, like 360 degrees there, then less chances of ischemia. Okay, so the testis may become twisted twice, then we'll call it 720 degree twist. And if it gets twisted single time, then it's 360 degree twist. And the duration is also, the second factor is the duration. If within 6 hours it is untwisted or treated, then 100% chances of testicular salvage is there. And if more than 6 hours, then less chances. Like if 24 hours has passed, then only 20% chances are there of salvage. Okay, so it's affected by 2 factors: extent of the twist and duration of the episode. Clinical features can in 25, this condition can occur 10 to 25 years of age, and patient will present with agonizing pain in the groin and the lower abdomen, and patient may present the nausea and vomiting. The scrotum gets swollen and tender, while the skin is usually not erythematous. So the skin will not be erythematous. Only the scrotum is swollen and tender. So this is the differentiating point with the infection like bronchitis. The skin will also be involved. And in this torsion, the skin will stay normal, but the testis will become tender and so. The other is that the patient may present with the apyrexia. So there will be no fever in cases of the torsion of the testis. But if it is infection like the bronchitis, and the patient will present with pyrexia. So these two are the differentiating points. Like the scrotum will be swollen in both conditions, but the overlying skin will be normal in case of the torsion, and there will be no fever in the torsion. And the testis itself is swollen and tender, and it will be high in the scrotum. And the twisted cord will be tender, and it can be palpated above it. So the cord will become tender, also will become tender, and will palpate above the testis. And the testis will be swollen and tender, and it will be high. No pyrexia or no fever, and skin will be normal. These are the features of the torsion. And there will be history of fall or sudden abdominal hard work, or fall, or the high, or like contraction of the abdominal muscles. Some event leading to contraction of the abdominal muscles. And there will be a fall, cycling. During cycling, this will be the history of the patient presenting with the torsion of the muscles. And differential diagnosis, we can differentiate with the epidermolysis on basis of the features which I told you during the discussion, like there will be no pyrexia, there will be the skin will not be reddened, and there will be no pyrexia, and the testis will lie high up, and only the testis will be tender and swollen, and the overlying skin will be normal. There will be no history of the UTI. In epidermolysis, there will be history of the urinary tract infection as well. So, the other differential diagnosis, the mumps, which is the mumps orchitis, it's also inflammation, and there will be history of the parotid gland enlargement also in this condition, in this mumps orchitis. Or you can differentiate with the small, hence strangulated uterine hernia. It's also a painful condition, but in this, there will be history of the hernia, instability, and after some period, it gets obstructed or irreducible, obstructed. So in this way, you can differentiate between these three are the differential diagnoses of torsion of the testis. But in torsion of the testis, there will be history of fall or abdominal contractions, otherwise normal patient. And these are a little bit, orchitis, there will be history, a little longer history. It wouldn't be a sudden history of these conditions. And in the strangulated hernia, there will be a sudden pain, but the hernia, if you go in detail of the history, then there will be a reducible hernia history as well. Investigations for torsion of the testis, color Doppler ultrasound scanning can confirm, and it will show that the blood supply to the affected area is not or is absent. There might be false positive results. If there is any doubt, then exploration should be done to save, and the time should not be wasted. If there is delay in diagnosing or investigating, then the testis may be lost. So it should be done early, and if the facility is not available, then better to explore early than sending patient for this for a doctor. So this is a picture of a patient, 14 years old patient with the torsion of testis. This right testis is, you can see the blood supply over here, red and blue. This is the venous, and this red are on the blood supply. And on this side, contralateral side, on the left side, you can see there is no blood supply over here. So this way you can differentiate between them, and you can firmly diagnose that patient is having torsion of the testis. And it is 89% sensitive, this color Doppler, and 98% specific color. But it is operator dependent. The operator give you diagnosis, you have to believe on the operator. Okay, so this is the gold standard to diagnose this torsion of the testis. So exploration should be done when transverse scrotal incision. If the testis is viable, then it should be untwisted and see now the testis will change the color, and it should be fixed with non-absorbable sutures between the alveoli of the testis and scrotal raphe. Okay, so the steps are transverse incision should be given, and if the testis is seen viable, then it should be untwisted. The testis should be untwisted, and then color change will be seen. So it will confirm that the testis is viable. Then the testis should be fixed with non-absorbable sutures like proline from the alveoli to the testicular scrotal raphe. And the other side should also be explored and fixed, because there are high chances of testicular torsion on the other side, contralateral side as well, because of the universal disturbance which is present on one side, so it can happen on the other side. So on exploration, the affected side should be explored and untwisted and fixed, and the unaffected side should also be explored and it should be fixed. Same. This is the testis which is gangrenous and it needs the removal. These are the two types of the testicular twisting. This is extravaginal twisting and this is intravaginal twisting. This is extravaginal means that this layer is also involved, and it's seen in the neonates commonly. And in this intravaginal twisting, this is the layer of the tunica vaginalis which is parietal, and it is a high investment, like it is fixed with highly on the upper side of the testiference, and inside the testis is twisting. And this layer is unaffected. This is seen in the adults, like adults. Okay, and this is seen in the neonates. These are the two types of the twisting: epididymal and extravaginal. This one is extravaginal and this is intravaginal. So it is extravaginal seen in the neonates. The whole unit is rotating. Intravaginal in the adults means the testis only torn, while the tunica vaginalis is not. And in adults, we give incision over the testis. But in the children, like in neonates, we give incision through the inguinal incision which is done, because usually it is accompanied with the hernia. So both should be treated simultaneously at the same time. So if the patient presents in neonate with the torsion, then it should be done with the inguinal incision, and if hernia is present along with the torsion, then hernia should also be treated along with the torsion to be twisting, the rotation of the testes. Now let's move towards the epidermal orchitis. This is the inflammation, as the word says, it's inflammation of the epidermis and testes. So if only epidermis is involved, then we call it epidermitis. And if the inflammation is present in both epidermis and testes, then we call it epidermal orchitis. And if only testes is involved, then we call it orchitis. So these three terms are used: epidermitis, epidermal orchitis, and orchitis. What's the pathophysiology? Usually the infection comes from the urethra, and which is the epidermis via the primary infection is there in the urethra, posterior vesicle, and it ascends in the epidermis. And usually the common organism is chlamydia or gonorrhea, gonorrhea. And in older people who are catheterized, it is because of the long-standing catheterization, which can lead to this urethritis, and then this infection will ascend, and it will lead to appendicitis. So the infection really starts in the rest of the, and then it goes to the testis. And these are the complications. If it is not treated properly, then abscess formation may be seen, testicular atrophy or infarction can be seen, and chronic indurration or inflammation or can lead to infertility as well, if the damage is so much. Okay, so these are the complications and the pathophysiology, and we move to conclusions how the patient presents. There will be pain in the groin and fever, epididymis, and testis will be swollen and painful. So pain may be seen in the torsion as well, but in the torsion there will be no history of the fever, and fall becomes edematous and involved, inflamed, adherent to the epididymis. And in case of the torsion, the wall is not involved; it's not red. Okay. And investigations, ultrasonography, urine analysis. There will be UTI or tract infection. Lymphocytes will be there in the tract, and swab can be sent for culture sensitivity, and accordingly the patient should be treated. And ultrasonography can be done by the abscess. So these three investigations can be done to confirm the diagnosis. And the treatment is usually conservative. Antibiotics should be given. Prostacyclin can be given for 2 weeks, or quinolone can be given for 2 weeks. And if an organism is isolated, then antibiotics should be given according to culture insensitivity. And plenty of water should be given to the patient, and total support should be given, analgesia. So antibiotics should be given, plenty of water, and total support, and analgesia should be given. And if the situation comes like if it involves a wall and the wall abscess is there, obvious abscess is there, then abscess should be drained. Okay, so this is the treatment of acute epididymitis, and it may convert to the chronic epididymitis. If the antibiotic is not taken properly, then it may the acute episode does not resolve, and it may convert into the chronic epididymitis, in which the intermittent episode of discomfort will be there, and epididymis will become thickened. And treatment is again proper usage of the antibiotics, and the antibiotics should be given for about 4 to 6 weeks. In case of the chronic non-tuberculous, and it may be a tuberculous epididymitis. The chronic one can be divided into non-tuberculous and tuberculous, and if the tuberculous is there, and again the tuberculosis comes from seminal vesicle, and the patient will have a firm, uncomfortable swelling in the lower pole of the epididymis, and the disease progress, and the epididymis becomes craggy, and lax hydrocele may be seen. So this hydrocele will be called secondary hydrocele. Again, as I described about the varicose, there is no reason, and the condition is idiopathic, then we call it varicose, primary varicose. Same way, hydrocele, if there is no reason and only the fluid is accumulated, there is no disease behind, then we call it primary hydrocele. And in this condition, because of the inflammation, the fluid is there, or because of the tumor, fluid is there, then we call this hydrocele as a secondary hydrocele. And in a tuberculous one, fluid abscess will be seen. So mostly the chronic tuberculosis, the chronic epididymitis are seen in the cases of the testicular, in the tuberculosis. And for the treatment, the same guideline is there for this tuberculosis orchitis as the other conditions in the tuberculosis stage. Investigation should be done, ASR should be done, PCR should be done, and the diagnosis should be established, and then ATT anti-tuberculous therapy should be given to treat this condition also, as we give anti-tuberculous therapy in case of the pulmonary tuberculosis or intestinal tuberculosis. So the other part of it is other part of the lecture is the testicular tumor. So it is one part of it. The testicular tumors, 2% of all malignant tumors are testicular tumors, and commonly they are seen between 15 to 25 years of age group. And the common cause is cryptorganism like undescended testes on both sides, and intersex disorder. Some testicular atrophy is experienced because of some other pathology in that testis. There are chances of the tumor formation or some chromosomal abnormalities there, and then the patient can have this tumor. There is some sex hormone fluctuation, estrogen administration. It can lead during pregnancy. It can lead also to testicular tumors. These are the hypothetical causes of testicular tumors. Classification: primary tumors of the testis, like germ cell tumor, non-germ cell tumor, secondary neoplasms coming from any other part of the body, and paratesticular tumors. These are the broad classification of testicular tumors. Germ cell tumors are usually testicular seminomas, 40%, and teratomas, 25-35%. Combined seminomas and teratomas, 14%, and testicular tumors, 1.5%, lymphomas, 7%. The tumors are 5.5%. So mainly, the burden is over seminomas and teratomas. These are the two main tumors which are present in the testis. The lymphatic drainage, primary drainage of the testis follows the testicular arteries to para-aortic lymph nodes. So if the tumor is there, usually the seminomas, they drain into the para-aortic lymph nodes, and these lymph nodes may be enlarged into the seminomas. But if the lymphatics of the scrotum is concerned, then it moves to the inguinal lymph nodes. The testicular tumors, it will not drain into the inguinal lymph nodes. In case of the testicular tumors, the nodes which will be enlarged will be the para-aortic rather than inguinal lymph nodes. And the lymphatics of the epididymis, it will drain into the external iliac chain. So the lymphatics of the testis goes to the para-aortic nodes, lymphatics of the scrotum goes to the inguinal lymph nodes, and the lymphatics of the epididymis goes to the external iliac chains. Inguinal lymph nodes may be enlarged if the primary tumor involves the scrotum. If the tumor gets adhere with the skin of the scrotum, then and skin of the scrotum is involved, then inguinal lymph nodes may be enlarged. Or if there's prior surgery of the inguinal or scrotal surgery is there, prior surgery, then it may be involved. The inguinal lymph node may be involved. Or retrograde involvement can be there. If the massive spread of the lymphatics is there in the para-aortic, then it will come back and it may involve the inguinal lymph nodes. So in these three circumstances, the inguinal lymph nodes will be involved. Otherwise, testicular tumor will not involve the inguinal lymph nodes. What are the clinical features? It's a painless swelling of the one testis and dull ache or heaviness of the lower abdomen. 10% will present with the acute scrotal pain, and 10% will present with the metastasis like neck mass, cough, anorexia, cough because of the pulmonary involvement, anorexia, vomiting, backache, and lower limb swelling. The patient may usually present with the painless swelling of the one testis and heaviness in that testis is the common presentation. but it may present, 10% may present the external pain or may present the metastasis. 5% may present with gynecomastia, and really it may present with the infertility. So these are the clinical features which are present in the testicular tumors. And physical examination, the contralateral testis will be normal, and this involved testis will be firm to hard. It will be the involved testis will be firm to hard, fixed, and it will be enlarged. And seminoma expand within the testis as a painless rubbery enlargement.
सर आपकी स्लाइड्स शो नहीं हो रही.
स्लाइड शो नहीं हो रही, बिल्कुल नहीं हो रही
नहीं
यार, तो पहले बता दिया भाई.
सर अभी नहीं.
हाँ, अभी नहीं हो रही. अभी हो रही, अभी हो रही. हाँ
नहीं सर, नहीं
नहीं
सर.
हो रही. अच्छा, एक मिनट, आप मुझे दोबारा से करना पड़ेगा. सही,
हो गई सर.
हो गई. तो I have to start again.
सर चैट देख लें, चैट स्टूडेंट्स.
अब हो रही है ना? हेलो, अब हो रही?
जी सर हो रही है.
अच्छा, ठीक है. So the testicular tumors, the other part of my presentation is testicular tumors. It's present 1-2% of the all malignant tumors, and most commonly it presents in the 15 to 35 years of age group. And these are the causes of the proposed causes of the testicular tumor, like crypto or keratoconusum. This is the bilateral undescended testis. In that patient, there are chances of producing tumors, and there are some intersex disorders, such as testicular atrophy, some chromosomal abnormalities, or some sex hormone fluctuation like estrogen administration during pregnancy. These are the causes, probable causes of testicular tumors. And it can be classified, the testicular tumors can be classified in primary classes of testis. These are the germ cell tumors, non-germ cell tumors, secondary neoplasms, and paratesticular tumors. Basically, we are concerned with the germ cell tumors. The common germ cell tumors are seminomas and teratomas. 40% of the tumors are seminomas, 25-35% tumors are teratomas. And combined seminomas and teratomas are 14%, interstitial tumors are 1.5%, and lymphomas are 7%. And other tumors are 5.5%. So mostly they are seminomas, 40%, teratomas 35%. And the lymphatic drainage of the testis is usually that it follows the testicular arteries and goes to the para-aortic lymph nodes. And from scrotum it goes to the inguinal lymph nodes. So the lymphatics of the scrotum goes to the inguinal lymph nodes. The testis goes to the para-aortic lymph nodes. So usually when the tumor is there in the testis, when the testicular tumors are there, then they will go to the para-aortic lymph nodes rather than inguinal lymph nodes. And if the lymphatics of the epididymis, it drains into the external iliac chain. So there are three types of the lymphatics. So the lymphatics of the epididymis goes to the external iliac chain. The lymphatic of the testis goes to the para-aortic lymph nodes, and lymphatics of the scrotum goes to the inguinal nodes. And if inguinal lymph nodes are present or because enlarged with the testicular tumors, then it may be because of the involvement of the scrotum, or if there is a prior surgery of inguinal surgery or scrotal surgery is being done, or if there is retrograde lymphatic spread secondary to massive retroperitoneal lymph node deposits. So these three are the causes of inguinal lymph node enlargement in case of testicular tumor. And usually the testicular tumor does not present with the inguinal lymph node enlargement. It only presents with the inguinal lymph node enlargements in these three conditions, like scrotal involvement is there because of the primary tumor, or there is prior inguinal and scrotal surgery, or there is high deposits of the retroperitoneal lymph nodes. And clinical features, how the patient presents. The patient presents with a painless swelling of one testis. It's enlarged and heaviness is felt on that side. There will be a dull ache in lower abdomen because of the heaviness of the testis. And 10% may present with the respiratory pain or even the metastasis like neck mass, cough, or anorexia, or may present with the hypomastia because of the testicular like hormone disturbances and increased estrogen level, and then the patient will present with hypomastia or rarely infertility. So mainly the main presentation of the tumor is painless swelling of one side and enlargement and heaviness of that side. So physical examination, the contralateral testis will be normal, and this testis will be firm to hard, fixed and enlarged. And seminoma will present with the rotary arrangement, enlargement, it will be painless and enlarged. And teratoma will produce as an irregular rather than discrete mass. Okay, so there will be a clinical difference between the seminoma and teratoma will be the teratoma will present with an irregular rather than discrete mass, and this seminoma will present with the large painless swelling, rubbery enlargement. Okay, the differential will be again the hydrocele. Hydrocele is the accumulation of fluid between the lateral and distal layer of the testis. Maybe epidermolysis, but epidermolysis will be painful, and so this tumor will be painless. And hydrocele, there will be massive enlargement of the scrotum, but the testis will not be palpable because of the hydrocele. And the trans-elimination test will be positive. So these are the differentiating points from the tumor. And in case of the epidermolysis, there will be skin involvement may be there, and the testis and epidermis will be painful, inflammatory condition is there. And if you compare the testicular tumor, it will be just enlargement and heaviness. And inguinal hernia may come at the heading of the diagnosis, but in hernia there will be a history of reduction of swelling, reduced swelling during lying. And there may be hematoma. The previous history of the trauma, there are chances that hematoma will present with the testicular swelling. It will be again painful. The testicular torsion may present with a like tumor, and syphilitic infection is there, and enlargement of the testis because of syphilis. It may come under the heading of different diagnosis of the testicular tumor, but there are some differentiating points through which you can differentiate between tumor and these conditions. Dictum or saying for this for any solid scrotal swelling is on the patients if they present with the solid mass and there is no pain. All the patients with a solid, firm intratesticular mass that cannot be trans-eliminated should be regarded as malignant unless otherwise proved. Okay, so if you come across a patient with solid mass of the testis and it is not transplantable, then there are high chances of the patient having malignancy. And scrotal ultrasound can confirm the diagnosis. It's a reliable technique to exclude the hydrocele damage, and it can diagnose the tumor. Hypoechoic areas within the genital albuginea is not suspicious for testicular cancer. These are the hypoechoic areas, and which are the suspicion for testicular tumor. So there are two main tumor markers are also there. And then can be detected in the blood, and the diagnosis can be confirmed by alpha-fetoprotein and human chorionic gonadotropin. These are the onco-fetal substances and cellular enzymes are lactic acid dehydrogenase and placental alkaline phosphatase. These hormones will be raised, these markers will be raised. It will lead to confirmation of the diagnosis. This alpha-fetoprotein normal level are 16 nanograms per milliliter, and raised are seen in non-seminomatous germ cells, like in teratomas. If the AFP is raised, then there are high chances of teratoma. And it can also be seen in liver cancer and uterine cancers. But it is high levels are seen in the teratomas. And HCGs are seen in the seminomas. Normal value is 1 nanogram, that's 1 nanogram, then raised are seen in both types of tumors. If the HCG is present, then it means that both possibilities are there, seminomas and teratomas. Role of the tumor markers. What is the role of the tumor markers? You can confirm diagnosis. Actual diagnosis in 80 to 85% of the cases, and most of the non-seminomas have raised markers. Only 10 to 15% non-seminomas have normal marker levels, and after orchidectomy, if the markers levels are increased, it means that residual disease is there. So you can follow after the surgery or orchidectomy. If the markers are increased, then there are chances of the residual disease. So you can follow through the markers, and you can diagnose the case tumors, the testicular tumors through the markers, increased markers. And elevation of markers after lymphadenectomy means stage 3 disease. Role of the tumor markers, degree of the markers that appears to be directly proportional to tumor burden. If the high levels are there, then like high levels or high reading is there, then the more tumor burden is there, and it indicates histology of the tumor as well. So if AFP is elevated in seminoma, it means that it has got non-seminoma interest elements. Negative tumor markers becoming positive on follow-up means that the recurrence of the tumor is there. So these are the importance of the tumor markers. And tumor and imaging, chest X-ray or CT abdomen can be done. Chest X-ray rule out the distant metastasis, and CT abdomen for find out the intrapetal software air. Tumor staging can be done on the TNM basis. T stands for the size of the tumor, and as TX means cannot be accessed, the tumor cannot be assessed. Then TO means no evidence of the tumor, and then TIS is carcinoma in situ. And the T1 is there, then it is limited to the testis and appendix, and no lymphatic as well. So the T1 is there, then it is limited to the testis and appendix. And if the T2 is there, then lymphatic invasion is also there. And if T3, then you may invest the lymphatic cord as well. So in T1 only limited to the testis and appendix. T2 is causing involvement of lymphatics and spermatic cord is involved, and T3 is T3. And T4 means invasion of the testis of the scrotum. The regional lymph nodes know if the lymph node which are involved 2 centimeter or less, then we call it N1. N0 is no lymph node involved. If the lymph node is 2 centimeter or less than it, then it is N1. And if it is more than 2 centimeter and less than 5 centimeter, then it's N2. If it's more than 5 centimeter, then it's N3. So N1, 2 or less than 2 centimeter, N2, 2 to 5 centimeter, and N3, more than 5 centimeter. And distant means no evidence. M0 is no evidence of the distant. M1 is non-regional lymph nodes or pulmonary metastasis, and non-pulmonary visceral metastasis. M2, it's involving the other viscerals. If M1 is there, then pulmonary metastasis is there, and if M2 is in M2 there, then non-pulmonary visceral metastasis. So if we will simplify the stages, stage 1 means localized to testes. Stage 2 means from the testis it goes to the retroperitoneal para-aortic nodes, but below the diaphragm. So stage 1 only involving the testis, stage 2 involving the lymph nodes, but below para-aortic, but below the diaphragm. And stage 3, testis is definitely involved, and testis goes to the beyond para-aortic nodes, above the diaphragm. And stage 4 is pulmonary hepatic metastasis. So you can simplify, you can memorize this simple staging that if it is stage 1 is there, only testis is involved, stage 2, para-aortic nodes involved but below the diaphragm, stage 3, above the diaphragm, para-aortic nodes are involved. And stage 4, pulmonary hepatic metastasis. Principles of the treatment should be aimed at one stage above the clinical. Like if the stage 1 is there, then stage 2 should be treated. Seminomas are sensitive for radiotherapy. Teratomas, they are resistant to the radiotherapy. They may give some result to the chemotherapy and surgery. Advanced disease should be the response well to the chemotherapy both. So seminomas are radio sensitive, and non-seminomas, they are radio resistant. Radical inguinal operectomy should be done. This is the first line of therapy, and it should be done with the inguinal incision. The whole testicle with the damage and spermatic cord should be removed. And lymphatic spread initially goes to the retroperitoneal. So lymph node dissection can be done. Early hematogenous spread is rare. Bulky retroperitoneal tumors and restrict tumors clinically down the stage with the chemotherapy. Also on the diagnosis, if lymph nodes are too much enlarged, then initially chemotherapy should be done to down stage it, and then it should be treated. Transscrotal biopsy should be done because it can involve the scrotum as well, and it may lead to spread to the inguinal lymph nodes. So the transscrotal biopsy of the testicular tumor should not be done. The inguinal approach should be done for the removal of the testis. The chemotherapy given in teratomas like is BEP, bleomycin, etoposide, cisplatin. These 3 drugs are used for the chemotherapy of testicular tumors. Thank you very much for listening. If you have got any question, you can send me. I will try to reply.